Without further ado, our first speaker is Dr. Karl Borsody. He attended medical school at the Medical College of Ohio and completed his surgical training at New York Medical College. He went on to fellowship in cardiothoracic surgery at Loyola Medical Center and has been in practice with Kettering cardiothoracic and vascular surgeons for the last 4 years. He previously lived in Missouri, where he was a professor of surgery at Washington University. Dr. Borsody.
Well, thank you, Lewis, and thank you, Dr. Einstein, for inviting me. And particular thanks to the Tatar Family Foundation Cancer for providing sponsorship for this cancer symposium today. I'm going to be starting out with a discussion about the surgical treatment for metastatic disease to the lungs. Introduction. The resection of pulmonary metastasis was performed over 120 years ago in 1892 by Dr. Weidenlacher for a metastatic rib sarcoma. This was successfully treated with resection of the lung and the associated chest wall lesion simultaneously. The first case series consisted of 24 patients undergoing pulmonary resection, which was done in 1947 by Alexander Haidt. He had 10 patients. 10 of these patients had pneumonectomies, and 12 had lobectomies done for metastatic lesions. This is pretty a radical surgery for a simple metastatic lesion. And in the 1970s, experience from major thoracic surgical centers suggested a more liberal indication with less lung tissue being removed for pulmonary resection and pulmonary mets. So initially they felt that, and they probably needed to remove an entire lobe just to remove a small lesion. But as things became more advanced with staplers and surgical techniques, small segments and wedge resections were able to be performed safely, preserving lung function for these patients. So how frequent is this problem? The incidence in autopsy studies of patients who died from extrathoracic malignancies found that 20% to 50% of those individuals were found to have pulmonary metastatic lesions. Also in these same studies, about 10 to 15% had isolated metastatic lesions to the lungs. These are patients who would be potentially treatable for their cancers. The number of metastases varied, with sarcomas tending to have more solitary, 1 or 2 nodules, while breast and colon cancers would have multiple nodules. So how does the cancer get to the lungs? The pulmonary arteries are the most common route for the metastatic disease to travel to the lungs. So it's hematogenous spread from either the colon, the breast, or any other source. Less commonly, pulmonary metastasis occur as a direct consequence of lymphatic spread, direct invasion, spread from adjacent organs. Spread to mediastinal lymph nodes occurs most commonly with melanoma, then breast, colorectal, and final renal cell cancers can also spread to mediastinal, hilar, interthoracic lymph nodes. And that's something we pay attention to during the time of surgery to fully evaluate those nodes to make sure that there is no lymphatic involvement. The diagnosis of these patients were previously treated for extrathoracic malignancies and are now found to have a new lung nodule. Of these nodules, 46% will have metastatic malignancies. So you can pretty safely say that the patient has a 50% chance of having a metastatic malignancy if they've had a prior cancer, a new lesion. 32% will be a new primary lung cancer. 18% will be benign lung disease. Most of these nodules are asymptomatic, particularly if they're peripheral lesions on the outside of the lungs. But if they're central lesions, hilar lesions, they can have symptoms of cough, pain, or hemoptysis. So most of these metastatic malignancies are found incidentally in post-op CT scans or PET scans that are done for surveillance after the primary tumor has been removed. The imaging studies that are frequently involved with finding these metastatic deposits. Chest X-ray is often nonspecific and shows an irregular or possibly calcified mass. We've moved away from chest X-ray for post-op surveillance of most malignancies in favor of new high-definition CAT scans and PET scan. CT of the chest is the main diagnostic tool used now by surgical oncology and thoracic surgery. Lesions greater than 10 millimeters in size are identified about 100% of the time. It's almost impossible to miss those 1 centimeter nodules in the lung. Lesions between 6 and 10 millimeters are identified 66% of the time. Lesions less than 6 millimeters are detected approximately 48% of the time. But this is always an improving area with better and better CAT scans, finer cuts. 2-3 millimeter cuts are now common, so these 6 millimeter nodules are being detected more frequently. PET scans are also becoming more and more useful to determine the extent of the disease, but they should still be used with CAT scans to improve the accuracy of finding smaller nodules that may be missed with PET scan alone. So this is a left upper lobe metastatic cancer. You can see right here. This is a patient I operated on recently. He's a 31-year-old who had a history of a tongue squamous cell cancer, resected a little over a year ago. He presented a few weeks ago to the office with this left upper lobe mass. This was resected by a VATS with good margins, and he did well post-operatively. But even though we're not going to talk about squamous cancers of the head and neck, they also will go to the lung. And this was in a very young individual. Methods for biopsy. This slide is for patients who we're not sure of. They have a lung nodule. You're not sure, is this a malignancy, is it a benign lesion, or is the patient too sick to undergo a wedge resection of that mass? Bronchoscopy is good for direct visualization or positive biopsy in about 25 to 50% of the patients with metastatic disease. Bronchoscopy is particularly useful if it's a central lesion involving the carina of the trachea or the hilum, and the other adjunct which we use preoperatively to biopsy these lesions is fine needle aspiration by CT guidance. The accuracy of fine needle aspiration is 84 to 95%. The only problem with FNA is that we will have usually less than 30% will have a pneumothorax, but up to 30% can. FNA is useful for poor operative candidates in whom surgical resection is not possible to make the diagnosis to get them further treatment. Now, on to the prognostic factors. This is from the International Registry of Lung Metastasis. This is a long-running registry of about 30 years in length now. It's collected thousands and thousands of patients from different kinds of malignancy. So the important prognostic factor for any metastatic or oligometastatic deposits to the lungs are the length of the disease-free interval, which is the time from the resection of the primary tumor to the appearance of the lung metastasis. The number of metastases, so obviously if they have a single metastasis is much better than if they have multiple spread over both lung fields. And the third important prognostic factor is the completeness of the resection that the surgeon can perform. And the International Registry has stratified into 4 groups. As you can see here, Group 1, which is resectable, had a disease-free interval of greater than 36 months and a single mass. They had quite good survival in months, almost 5 years, 61-month survival for those individuals in the Group 1. Group 2, again, they are resectable individuals. They had disease-free interval of 36 months, but they had multiple lesions. What do we mean multiple? 2, 3, 4 lesions. Usually when you get more than 5, 6 lesions, they're not considered to be resectable. So they had the survival did drop to 34 months in that Group 2. Group 3, again, was a resectable lesion. They had disease-free interval less than 36 months, and they had multiple lesions with survival of only 24 months. And Group 4 was not a resectable group, and they had survival of only 14 months. So the selection criteria for resection, these are pretty much universal for all, any type of histology for malignancy. The primary tumor must be well controlled, fully resected. There is no evidence of widespread extrapulmonary disease, and the patient has a good surgical risk and is expected to have adequate post-surgical lung reserves. So the pulmonary function tests preoperatively are important. The additional indications for surgical resection, other things we look at, is the need to establish a diagnosis. Again, many times patients will come with a small nodule with a history of having some form of malignancy, and we go in minimally invasively and remove that to determine if and what type of cancer it is. Other indications for surgical resection are removal of a germ cell tumor or other residual tumor after surgical resection. And obtaining tissue for pathological staining or immunohistochemical studies is also an indication that we all sometimes get for resecting these lesions. The surgical treatment principles that we as thoracic surgeons use is removal of the least amount of lung tissue while removing the entire metastatic lesion. Inadequate margins require re-excision to reduce the possible future local recurrence. A recommended margin on these lesions is 0.5 to 1 centimeters ideally. Most of the metastatic lesions tend to be peripheral, and these can be removed by wedge resection. Again, if it's a more central lesion, if it's involving the bronchus or hilum, then a lobectomy is occasionally used, but it's becoming more and more rare as we refine our surgical techniques. We try to preserve as much lung function and lung volume as possible because many times these patients will come back for re-excision. Surgical treatment continued. Lymph node dissection, as we mentioned, dissection of mediastinal and hiatal lymph nodes is indicated at the time of surgery, gives an accurate staging, and guides postoperative therapies. The presence of metastatic lymph nodes at the time of metastectomy does have a negative survival effect. 3-year survival without nodal involvement is 69%. 3-year survival with positive nodes drops to less than 38%. So it has a profound impact on the long-term survival and whether or not these patients need post-operative treatment. The surgical approaches, I'm going to talk now a little bit about the surgical exposures. The survival between all of these exposures is similar, assuming that all the disease is resected with adequate margin. So the terms we're going to go through here for the non-surgeons is thoracotomy, which is, we'll talk about, most commonly done. Videoassisted thoracoscopy, which is now being more and more often used, a median sternotomy, and a clamshell incision. We're going to go through the first 3 surgical exposures here. So the types of thoracotomy. Thoracotomy is the oldest of thoracic surgical incisions. The standard full thoracotomy are 3 types: posterior lateral, anterior axillary, and vertical. The posterior lateral basically starts posterior near the spine, goes underneath the tip of the scapula, and comes around anteriorly. Anterior axillary is going to again be more anterior on the underneath the intermammary fold, and a vertical incision is up and down, which is not very often used. And then limited thoracotomy, which I use quite often, is a muscle-sparing mini thoracotomies. Are used to preserve the functional musculature of the chest, as well as reducing the scar and the pain postoperatively. So this is an example of a posterior lateral thoracotomy. The incision is done between the 5th and 6th intercostal spaces. The latissimus dorsi, the serratus anterior, and the intercostal muscles are divided, and the ribs are spread. So this incision usually will carry from here posteriorly close a few inches to the spine. It's a large incision and quite painful, and this was an incision quite often used by my forefathers in thoracic surgery, but is becoming less and less used today. Nowadays, we use muscle-sparing thoracotomies for lung resection, where the latissimus and serratus muscles are spared. Usually through a 3 or 4 inch incision, I'm able to remove and inspect the lung Video-assisted thoracoscopy is the current minimally invasive approach used most commonly for small lesions that are peripheral. Thoracoscopy is a procedure that uses a thin lighted tube connected to a video camera and monitor to view the space between the lungs and the chest wall. Using this, one can find small cancer deposits, remove a small piece of tissue to be examined. Thoracoscopy also is able to sample the lymph nodes. And this is done with 5 to 10 millimeter instruments, fiber optic technology, and long graspers. One downside we'll talk about with thoracoscopy is the inability to palpate or fully examine the lymph nodes. So while it's good because it decreases the hospitalization, length of hospital stay, the amount of pain, the complication rate is lower, it does have the downside of not being able to palpate the lung. How do we do a video-assisted thoracoscopy? Double lumen endotracheal tube is used. Anytime we like to operate on the lung, we like to have the operative lung down so it's isolated, so it's not ventilated. We like to have patients have minimal or limited intrathoracic adhesions for minimally invasive surgery. Peripheral lesions or large central lesions are best lesions for video-assisted thoracoscopy. Selective lymphadenectomy during a VATS is usually done because it is more difficult to do a complete lymph node dissection with the scope and the graspers. And VATS requires preoperative correlation with PET-CT and high-quality CAT scans for pathologic evaluation. It's also important to carefully identify the location of the lesions. So the two most common, VATS versus open thoracotomy. Open thoracotomy is the most researched surgical approach, and most of the papers before 1980 were done using thoracotomy. However, VATS is now becoming more used, particularly in the periphery of the lung. Bimanual palpation of the lung to determine complete surgical resection is done by open thoracotomy, but has been not shown to improve survival. Mini thoracotomy or muscle-sparing thoracotomies are now used more frequently to preserve the musculature, decrease postoperative pain. The mini thoracotomy still allows the thoracic surgeon to palpate the lung, and oftentimes I'll use it in conjunction with a thoracoscope to find any other additional small lesions that may not have been seen on the CAT scan preoperatively. So these are the two most common exposures used to get and do complete resections for these metastatic lesions. The third one I'm going to just mention is a median sternotomy. It's basically splitting the breastbone, splitting the sternum in the midline. It's useful for bilateral lesions if somebody has right and left-sided lung nodules. It tends to be less painful than a thoracotomy, similar to a VATS. They tend to have shorter hospitalizations than open thoracotomy. The chest tubes tend to come out sooner. It allows good exposure to both pleural spaces, the hilum and the chest wall. Unfortunately, the downside is its poor visualization of the costophrenic angles, the posterior side of the lung near the spinal, the vertebral column, and the left lower lobe is particularly difficult to do a left lower lobectomy through a median sternotomy. But it is, again, used in addition in the armamentarium of the thoracic surgeon to the other two surgical approaches. Now, any of these approaches have similar complications. Prolonged air leaks, bleeding, postoperative pneumonia, and empyema can occur. Airway complications from the double lumen endotracheal tube placement. Tumor seeding of port sites or incisions may have been more prevalent in the past. We're very careful nowadays, and it doesn't happen all that often. And prolonged intercostal nerve pain, particularly with thoracotomy, patients can come back even years later having chronic neuritis, radiating sensations, pain from the intercostal nerves. Complication rates are anywhere between 10 and 15%, with prolonged air leak being the most common. A few percent will have postoperative pneumonia, 1% may be bleeding. So overall, it's a very safe procedure, and the complications are relatively easily managed. Now, I don't have a slide on it, but the mortality rate, which we'll just say is about 1% for all comers, and has been going down. I reviewed about 20 articles, and it's anywhere between 0% to 1.5% to 2%. Extended resections for patients who have multiple metastatic lesions can be multiple wedge resections to a pneumonectomy for that patient, particularly if they're good surgical candidates. Median survival and initial disease-free survival did not differ based on the extent of the operation. So as long as you were able to resect all of the metastatic foci, their survival should be the same, regardless if it's a wedge resection or if it's a pneumonectomy. This thing has a mind of its own. Endobronchial metastasis in those that are centrally located can be resected, but these often require a lobectomy and pneumonectomy, and these do carry a higher complication rate, particularly pneumonectomy in these patients. So we avoid that in majority in almost all patients. Repeat resection is also common. So patients will come back after I remove a small metastatic foci with a VATS. They'll come back a few years later. They may have another one, particularly with melanoma or some of these cancers, and they have to be re-resected again. Presuming that the patient remains free of widespread metastatic disease, then repeated resections are possible. Even 3 or 4 times they can come back and have good results. The disease-free intervals greater than 40 months between metastectomies had a greater long-term survival. So basically what that is saying is the greater the period between the prior resection and the recurrence of their cancer in the lung, the better the long-term survival will be for those individuals. The people who tend not to benefit as much is when they come back on a very short few-month period of having a recurring pulmonary metastasis. These are the most commonly metastasizing cancers to the lung. You may not have all of the slides in here. Some things were added, but from number 1, colorectal cancer is the most commonly resected. Melanomas and the breast cancer, osteogenic sarcoma, soft tissue sarcoma, renal cell cancer, and finally germ cell tumors. I'm going to go into each of these briefly to kind of give you an idea. Colorectal cancer is most studied and the most common that I resect for metastatic spread. Colorectal cancer spreads either regionally into the local drainage basin in the abdomen or systemically to the liver and then to the lung. Rectal cancer can spread directly from the primary site to the lung, bypassing the liver. So it's something that sometimes confounds us. Pulmonary metastasis were typically found at a mean of 38 months after the primary colorectal resection was performed. Good prognostic factors, as for all metastatic cancers to the lung, is if it's a sole or single metastatic lesion, the disease-free interval greater than 36 months, and low CEA levels. And they mean low, less than 5 to 10 on the CEA. Patients with metachronous resection had much longer survival than synchronous resection, 70 months versus 22 months. What that's saying is if the patient has the colon resected and also has a lung nodule, and we resect them both within a short period of time or simultaneously, their survival is only 22 months. Now, if they have the colon resected and then 36 months later they have metachronous resection, then the survival is much longer, 70 months. For patients with controlled colorectal cancer, the actuarial survival rate in multiple studies is between 38 and 63%, with a mean of 53%. Even in cases with elevated CEA levels, 5-year survival is still significantly better after pulmonary resection than without pulmonary resection. It's almost double that. Even if they have high CEA levels preoperatively, it's still better to remove that small lung nodule than to leave it in. The second type of cancer, which we frequently see, is osteogenic sarcoma. And between 10 and 20% of osteogenic sarcoma will have parenchymal metastasis. Of these parenchymal metastasis, about 85% will be to the lungs. So it's not that common a lesion as colon cancer, but it has a preferential metastatic profile to go to the lungs. in a study by the National Cancer Institute evaluating multiple factors, only the number of nodules on preoperative CT scan correlated with survival. In patients with 4 or fewer nodules, their median survival was 37 months, compared to only 10 months for those who had 4 or more sarcomatous nodules. So this is kind of in a class by itself almost, the fact that it tends to go to the lungs preferentially, and the number of nodules in the lungs does affect the long-term survival significantly. And sarcomas in general tend to metastasize to the lungs as their nature, more so than a lot of the breast or other malignancies. Following the same course, soft tissue sarcoma. Our sarcomas, they frequently metastasize, again, only to the lungs. Metastectomy can yield 5-year survival rates of up to 30%. Factors affecting the 5-year survival, again, include disease-free interval greater than 6 months, fewer metastasis on preoperative CT scans less than 3 lesions, younger age, and completeness of resection. As a thoracic surgeon, we try to make sure that the patient has less than 4 or 5 lesions. If they have more than 4 or 5 lesions, it becomes difficult to adequately resect that, and then we assume that there are probably others that we won't be able to resect. So we try to find patients who have less than 5 lesions that need to be resected at one time, and would like to have them unilaterally. Even having said that, we have done bilateral VATs to treat patients who may have bilateral sarcomatous lesions. Just do one side, reposition them, and then do the VATs on the other side to remove multiple lesions that may occur, particularly with sarcomas, because removing all of the lesions for sarcoma does tend to give them a good advantage survival-wise. Breast cancer is not as common. We don't see many breast cancer patients who have isolated lung lesions. Breast cancer tends to metastasize to multiple sites, unlike some of the sarcomas or even the colon cancer, with up to 25% of breast cancer deaths being associated with pulmonary mets. A review of 467 patients from the International Registry of Lung Metastasis found that after complete metastectomy, the investigators noted a survival rate of 38%, 22%, and 20% at 5, 10, and 15 years. In the same paper, again, a better survival was found if they had solitary mass and a disease-free interval of greater than 36 months. Most of the time, patients with breast cancer will have pleural effusion and multiple lesions or multiple sites of lesions. Melanoma is particularly aggressive. Most individuals with melanoma will have extrapulmonary disease and will have poor overall survival. The International Registry for Pulmonary Metastasis shows that patients who have melanoma have worse prognosis after pulmonary metastectomy than those who have the other primary tumors that I mentioned before. Resection of isolated pulmonary nodules may result in a 5-year survival of only 22 to 27%. But we don't have a lot of good options for melanoma with systemic treatment, so these patients are often younger, and I have resected a few patients this year who have had metastatic melanoma. They tend to come back again, and these are the patients who will resect again, particularly if they're young, healthy, active individuals. We can do it minimally invasively, and oftentimes they'll only have 1 foci or 2 foci that show up at a time in the lung. The last type of cancer is renal cell cancer, another unusual actor. Renal cell cancer has a preferential spread to the lungs. They can have metastatic foci that appear decades after primary tumor is removed. I had a patient come back 19 years after they had their kidney removed with a small lung nodule, and again, this was found to be a metastatic renal cell cancer. A study of 191 patients with renal cell cancer with pulmonary metastasis had an overall 5-year survival rate of 37%. Complete resection yielded a survival rate of 42%, which is quite good, while incomplete resection resulted in a survival of 22%. These are the kind of patients that you can really get some worthwhile longevity on. These are patients who tend to do well, the renal cell cancers, particularly if it's small foci. It tends to come from the kidneys up the cava into the lungs, and it's usually a solitary mass found with a long disease-free interval after the cancer. So in conclusion, just some of the salient features from the surgical side of things. Metastatic disease to the lung can be resected with prolonged survival, particularly in certain histologies. Selection criteria is critical. The primary tumor must be well controlled. There must be no evidence of widespread extrapulmonary metastasis. And the patient should be a good surgical candidate with good pulmonary function test and lung reserve. The most important prognostic factors to take home are completeness of resection with negative margins. Disease-free interval, the longer the better. Usually 36 months is the gold standard. That's what all the studies have said. And the tumor histology does play a minor role, but some obviously are worse than others, melanoma being a bad actor. And we are getting more and more experience treating these lesions with newer modalities, which subsequent speakers will be talking about at this time. I'd like to thank you for your attention, and I'd like to entertain any questions that you may have at this time.
You mentioned if someone has non-resectable cancer, then FNA, pineal aspiration, you won't do it. Could you explain a little bit more? What if the cause of not doing adequate surgery is related, like you mentioned, the last part, to pulmonary function, so other reasons, yet whatever you have there is technically resectable, you would not do the FNA, or you would do that?
If the patient has a lesion and their pulmonary function tests indicate that it would be a poor surgical candidate, we would send them for FNA to make the diagnosis mostly, get tissue for our oncology colleagues so they could further treat them with one of these possibly newer modalities. And that's a good lead-in question because we a lot of times see these patients after they've had multiple courses of treatment, they're debilitated, and they are poor functional status, not really good surgical candidates. It's more the minority of the patient who comes in really good shape with excellent pulmonary function tests with a solitary nodule that can be removed. And I put that slide in to show that for the majority of patients who have multiple lesions, that we're able to do needle biopsy, and we have bronchoscopy as an alternative if it should be a more central mass that needs biopsy and treatment.
I have another question. In type of cancers that you mentioned, you resect one or two nodules and then shortly later, so not all cancers behave that way, but some have more metastasis. In view of the fact that cancer is a totally systemic disease and cells are all over, and they manifest sometime later, is there, maybe this is a stupid question, is there any interval you can wait till you get all of them at the same time, or you will go back frequently, one or two metastases removed? Now, some that comes far later, I can see the reason for that. But those you mentioned, such as melanoma, how many operations the man goes through to get all these metastases?
Exactly. And that's a good point. And there have been studies done that show there's no clear indication or reason to wait if you're certain that this patient has, or you have a good inclination that this is going to be a metastatic lesion. Some people will, if they have small nodules, they will wait 6 months to see if it is enlarging. If it is enlarging, particularly if it's hot on a PET scan, we will take those individuals and resect the lesions when we have an overwhelming amount of evidence that this is most likely a metastatic foci. Some people have said, particularly if the patient is a marginal surgical candidate, maybe wait six months, wait a period of time to see if other areas enlarge or start to show up, in which case they may not be as good a surgical. But certainly for young patients, I tell them right up front that this may be a repeat, may need to have multiple procedures done, particularly since we're only typically going on one side of the chest. The other side is not, we're not able to palpate that or inspect it clearly. It could occur on the other side, and it frequently does. It will frequently occur on the contralateral side, which wasn't palpated during the time of surgery. And in the surgical literature, typically patients, 2-3 procedures, and that starts to reach the limit. Even though there have been patients reported up to half a dozen surgeries to resect metastatic lesions, it's not common to take somebody back more than 2 or 3 times to take a piece of lung to try to prolong survival.
Another question, asking sort of along the same lines. For selection criteria, you mentioned no evidence of widespread metastatic disease, and sort of looking for some clarification as to what widespread entails.
In my opinion, it would entail a negative PET scan, thorough physical examination first to making sure there's no obvious lymphadenopathy, no obvious areas of mist. Speaking to the surgical oncologist, making sure that they are on board, making sure that they agree that this is something which should be resected. These are all things that we look at, and depending on the tumor markers, we do look at the CEA level for colon cancer, and different tumor markers that may be present can also be evaluated, making sure that there's no extrapulmonary spread of the disease. But usually it's a consensus among the surgical oncologist, the surgeon, and also the pulmonologists to see, this patient, yes or no, is going to be helped by this procedure.
Any other questions? Great. Thank you very much.
Thank you.